During this mini lecture, let's take the receptor discussion one step further. So I want you to see that drugs can interact with receptors in several different ways, and those differences will explain why some drugs will activate a pathway, and perhaps more strongly, and some only partially, and others may block the effect altogether. So that'll kind of be the highlight of this series of slides. Well, there are several major receptor types that you should recognize. And some receptors are ion channels, where a ligand is going to bind directly and change ion movement. Some are G protein coupled receptors, where the ligand is going to activate a secondary messenger system. Some are enzyme linked receptors, and others are intracellular or nuclear receptors. And this is where the drug has to get into the cell in order to influence the transcription. Now, you don't need to memorize every detail today, but you should understand that receptor type helps predict the speed of action, the location of action, and the kind of physiologic response that is going to follow. So there are some types of receptors, like an ion channel. For instance, you're familiar with a sodium channel, and sodium and potassium. Now, these can bind to the channel and change its shape and allow the channel to open. And we may use a drug to increase or decrease channel opening or closing. For instance, lidocaine blocks a sodium channel and reduces the feeling of pain. There's other G-coupled protein receptors where the drug is going to bind to a receptor and trigger a series of events downstream. Now, eventually, that ultimately ends up with an effect in that cell. So, for instance, epinephrine will bind a G protein receptor, and many G protein coupled receptors are directly involved in the development of insulin resistance and beta cell dysfunction. So insulin in your body facilitates, if we're familiar with that cascade of events, it facilitates translocation of the GLUT4 protein to the cell membrane to allow glucose to enter the cell. Now that of course requires phosphorylation, which is where there's an additional phosphate that changes the shape. But ultimately norepinephrine facilitates that binding, and that cascade of events leads to the glucose transporter protein making its way to the cell membrane. That allows glucose into the cell. Other receptors, they require two molecules to activate, different signaling pathways. And all of these receptor types have endogenous ligands in the body, as well as exogenous ligands. So endogenous within and exogenous, like drugs or medications that we can consume, that we can use to increase or decrease the effect. So an example might be levothyroxine, which is a medication that acts similar to thyroxine. So the hormone in your body can be mimicked by a drug that you're taking. Now, caffeine in coffee blocks adenosine receptors in the brain from receiving adenosine, which is a neurotransmitter that causes fatigue. So there's a whole cascade of different drugs, different endogenous and exogenous ligands that are going to interact with different areas in the body. So here we have the drug receptor binding, and this slide reinforces a point that's easy to forget in medicine. And it's easy to overdo in real life as well, that more is not always better, because drug binding is reversible. So the effect depends on how many receptors are occupied at a given point in time. It also depends on how strongly the drug binds and what happens after the receptor is activated. So once most receptors that can respond are already occupied, adding more drug, if all the receptors are occupied, adding more drug may actually add more risk without adding much benefit. In other words, that additional drug may now be circulating, not bound to receptors, and now it can cause a host of side effects. So in a patient or an athlete that thinks, okay, well, doubling the dose is going to solve the problem faster, that's often a misunderstanding of how the receptor system works. If all of our drug is bound to all of our receptors and we add more drug, there's not going to be an inherent rise in the response. So by increasing the concentration of the drug, we can overcome a lack of receptors in a sense, but we can't really change the effect of the drug. So let me give you an example. Smoking. Smoking has nicotine, which affects ion channels, and the more you smoke, the more the channel is going to be activated. Now, in this example, the body responds to the overload by, in a sense, making fewer receptors. In other words, you are constantly hitting these receptors with nicotine. And the body says, hey, this is an over exaggerated response. So, what can I do to fix the problem? I'm going to reduce the number of receptors that I have. So, now we have these fewer number of receptors. And when you quit, now there aren't as many receptors available for your endogenous ligands to bind to. And there's not as much to bind to. And now you feel horrible with the symptoms of withdrawal. Okay, so smoking's one example, but I think caffeine is one that more times than not universally can be understood as a practical example. So this is how receptor signaling can change over time. All right. Caffeine primarily works by blocking adenosine receptors, as I mentioned. Adenosine is an endogenous signaling molecule that tends to promote sleepiness, relaxation, reduction in nervous system activity. So under normal conditions, adenosine builds up during the day, it binds to the receptors and helps signal the body, hey, you're tired, right? And probably happening at the end of the day, it's bedtime. Well, when someone drinks caffeine, caffeine acts as an antagonist at those same adenosine receptors. So it doesn't activate the receptor in the same way that adenosine does, because adenosine causes you to be tired, but caffeine blocks the receptor. So instead, it occupies the receptor and prevents adenosine from binding effectively. Well, the result is that the person feels more alert. Not necessarily because caffeine is creating energy, but caffeine is blocking the body's fatigue signals. Okay, fair. Now, what if somebody consumes caffeine regularly? Well, we talked about this with smoking. The body adapts. So because adenosine signaling is being blocked again and again, the body may increase the number of these sensitive adenosine receptors. Now, in this case, the body is trying to restore balance by making the adenosine system more responsive. Well, this helps explain tolerance. Because over time, the same cup of coffee that you enjoyed in the morning may not produce the same level of alertness because now the system is adapted. The body got used to having all this caffeine and it got used to having all of these adenosine receptors blocked, so it created more adenosine receptors. So now you need more caffeine in order to facilitate the same alert response that you had prior. Okay, this also helps explain withdrawal. Because if the person suddenly stops taking caffeine, well, now there's no caffeine blocking those receptors. But remember, the number of receptors has significantly increased. So the body now has more available adenosine receptors than before. So adenosine can bind more effectively. And now the person feels unusually tired, foggy, irritable, develops a headache, right? These classic signs of caffeine withdrawal. So caffeine is useful as an example because it shows that the drug effects are not only about the dose taken, but they also depend on how the body has adapted. Did it create more receptors to offset that amount of caffeine, right? And then repeated receptor level stimulation, or this blockade over time, right? Did that facilitate an overall response in the body? So with drug receptor interactions, it's important to understand that drugs can interact with receptors in several different ways. A full agonist can produce a maximal biologic effect. A partial agonist binds the receptor but cannot create the same maximal response. Even if you increase the dose, that partial agonist isn't going to generate the maximal response. Now, an antagonist occupies the receptor and prevents the endogenous ligand or another drug from activating it. So this is why partial agonists and antagonists can both alter a response, but they operate in very different ways. Now, understanding those categories helps explain why drugs in the same general family can still behave differently in the body, because we know that drugs can do different things to receptors. So let's look at this dose response. There's a maximum effect, right? There's a full agonist drug that we're going to take, and this drug activates the receptor. So let's say 200 units of this drug initiates a maximum effectiveness. Well, then 200 units of the effectiveness is the maximum that we can give, because if we give more than that, it's not going to give that maximum effect. Now, some drugs, when given, they don't initiate a full response. So the most effect that you'll ever get is a partial effect. In other words, you give a certain amount of this drug, you get a partial response. You give more drug, you still have that same partial response. You give more drug. Okay, no matter how much you continue to provide, we're always going to have a partial response. Why would we do that? Well, it's a great question. Well, some pain medications like oxycodone or OxyContin, they act as full agonists to opioid pain receptors. And while these drugs are pushed by drug companies to make, well, albeit more money, they may not be as beneficial to patients in the long run, given the propensity of opioid addiction. They are full agonists. They do exactly what they're meant to do. They do a maximal response, but they are also highly addictive. So, enter the scene hydrocodone, or some would say Vicodin or Lortab, right? This acts as a partial agonist. Now, it has a partial effect, so you don't get the full hammering on that receptor, the full effect, and doesn't hit the receptor so hard. So the drug is prescribed, but it may also be dependent on the circumstances. For instance, let's say we have a cancer patient who's dying and in a lot of pain. And they may be prescribed different medication than somebody who is healthy but broke their leg, right? The propensity for addiction or use of this drug may not be necessarily as of great a concern depending on where we're at in the scenario. Now, in this example, let's take a look at the figure that's on the left-hand side there, and take note of the black line on the figure. So this represents the action of an antagonist, whose goal is to stabilize the receptor and initiate no response. So the antagonist may prevent the endogenous agonist from having an effect. Now, some drugs may have zero effect when they bind, then the normal endogenous drug can't bind. So we call these blockers. Give you an example, calcium channel blocker or beta blocker, right? In these cases, they're antagonists. They bind to the receptor and prevent the endogenous drug or the endogenous hormone from binding. Well, we also have what are called inverse agonists, and these have a negative effect on the receptor. So it doesn't just blunt the response, but it takes it to an even lower level to have a lesser reaction. Now, every receptor has an active site, and all have an agonist and an antagonist site, but some may have what's called an allosteric site. And this is something that we're going to discuss a little bit further. Now, I want to get into this discussion of the allosteric binding, but it's important that we understand that not every drug interaction occurs at the main binding site. So some substances act allosterically. And this means that they have a site where they're going to bind on the receptor or the enzyme and modify how the main site behaves. So think about an allosteric activator as one that can make the receptor more responsive, while an allosteric inhibitor can reduce the responsiveness. Now, this matters because two different molecules may influence the same receptor without directly competing for the same exact spot. So this gives the body and pharmacology a way to fine-tune the final effect. And so in this figure, you can see that there are agonist binding sites, there are competitive inhibitor binding sites, allosteric activator, and allosteric inhibitor. So remember, the allosteric component is going to alter the way that the main binding site interacts. And in the figure that's inset, you can see if we're looking at the log dose, in other words, how much, and then what the response might be. If we have A, which is the agonist alone, we get that kind of moderate effect. If we take A plus an allosteric activator, the effect is enhanced. So that's A plus C. The effect is enhanced. A plus B, where we have a competitive inhibitor, some of our receptors are going to be blocked. So our response might be a little bit lower. And then the allosteric inhibitor comes into play because when it's impacted, even if we have the agonist available, but it's shifted slightly the way that this enzyme looks, or the binding site, the way this receptor looks, well, A plus D, the agonist plus the allosteric inhibitor, might have, again, a lesser response. So, the takeaway from this section is that receptor physiology helps explain both therapeutic benefit and side effects. And once you understand receptor type and receptor interaction, many drug effects become much easier to predict.